Of course, there are many causes, and the whole purpose of doing a good revision is to identify why it went wrong in the first place. It would be a bit daft to repeat the same mistake just because that's the operation you know how to do. So it could have been the wrong patient, could have been an associated instability that was missed, could be non-compliance, could be their psychology and their ability to cope, could be the wrong surgeon. That still exists, sadly. It's poor decision-making, poor grafts and tunnels, poor technique, and of course, the rehab is very, very important, but I'm not going to go into that any further. So I think you've got to start again. Go back right to the beginning. Was this a high-energy contact injury? Was it a non-contact injury? What was the problem pre-reconstruction? What happened during the recovery? We've all seen the person who says, I had a fantastic recovery. It was all great for 9 months, and then when I stepped back onto the pitch, it went. The problem didn't happen that first day on the pitch. It happened 9 months before, almost certainly, or somewhere along the way. And is it an instability problem? Is it an unhappiness problem? What's actually going on here? You've got to really unpick it. It's time to actually stop and talk to the patient and not just look at the bits you want to look at. The other bit I keep stressing in these sorts of scenarios is you will get to learn your local ecosystem. You get to learn what happens around you. Your colleagues, those who don't have a 0% failure rate, will generally have a typical pattern of failure that happens to them, Dinesh. I've seen some of yours. So in reality, you get to recognize how things go wrong and where they go wrong. And based on the graft, based on the fixation, you get to see what goes on. Peter covered this beautifully. You've got to take a step further back and look at the whole patient. Look at their nutrition, their psychology, look beyond the knee joint. There's a lot to understand about the knee, but there's a lot more to understand beyond the knee, their overall alignment, their soft tissue quality, their slopes, etc. So there's no time to go through all of that, and Peter's much more eloquent than I am at presenting these things with pretty videos, but just look beyond that silly graft that we're all focused on. And always look for associated injuries. You know, my impression is there's lots of surgeons who've learned how to do an ACL. There aren't many who do a good MCL or a good posterolateral corner, so people tend to default to doing an ACL, and the rest is forgotten until there is a failure. So you've got to be aware of all of that as you go. And you've got to investigate them. People come with an MRI scan, but you may need other tests, and you're sometimes surprised. The challenge may be greater than you initially perceived in terms of the real estate you've got. Understand where the hardware is, how you're going to deal with it. CT is often helpful in really evaluating where you really are, where your defects are, and what you're going to do if you're going to do a proper, good, durable reconstruction. Know what the hardware that's in there, because you may think you can avoid it until actually you're trying to build the tunnel, you drill your tunnel, and you suddenly discover it is just where you want to be. So understand it and be able to get it out. It is not another primary. If you take away no other message, is you've got to identify why it's failed and not repeat that mistake for the second, third, or fourth time as you go along. I'm getting stronger here. So I think, as I said before, there's a technical element, there's a biomechanical element, and there's also a biological element in getting durable healing. And don't do this sort of thing. So also be careful what you say here. I think it's really important. If you're in the privileged position of doing revisions, don't land the other guy or girl in trouble when you're having that conversation with the patients. Mistakes happen. We all make them. So in reality, let's be kind when we're dealing with patients. Look after the patient, but also don't throw your colleagues under a bus. So you can break it into subsections in terms of algorithms, but you can have isolated graft failure, you can have secondary other ligamentous laxities, you can have non-graft related conditions in combination or separately, and you've got to be ready to deal with all of them. I'm sure I haven't here right at the beginning, I'm sure somebody's already addressed to you the real importance of the meniscus instability, because that's really key.